So, thank you, Dr. Hoxie. The next two panelists, and I'm going to kind of introduce them together because I think it makes the most sense, is Dr. Tom Retzky, who is an adult hematology oncologist and also a geriatrician. So he's going to be there to take care of me as I get older, I hope. And then Dr. Prasad, who is a pediatric hematologist oncologist. And Dr. Prasad trained at Vanderbilt, and I just have to say go doors a little bit because I was an undergrad there. But her area of expertise is in survivorship clinics. So what happens after children survive and adolescents survive. And she has a new clinic that she has started, I think, here called Tackle. Is that correct? And she'll go through, I'm sure, what that mnemonic is. But the reason I introduced them together is that while I think they may have a common vision, I think there may be some differences and some disparities that are fairly important between what each of them have to offer. Thank you, guys.
Thank you so much for that introduction, and I have to say I'm very honored to be here. And sort of the reason why I went into medicine is my dad used to be a pathologist. He trained up at Roswell Park Cancer Institute up in Buffalo, and by the time he trained, there were lots of diseases where, unfortunately, the only weapon we truly had was an autopsy to sort of, see where disease goes and what happens. And thank God, like Dr. Hoxie mentions, that with a lot of diseases these days, we have found cures. Having said so, I trained at Boston University. And the way oncology started, just to give you a historic perspective, is that it used to be a surgical discipline. And the way cancer was looked at, that it was sort of defined as, cells which have gone basically out of control, are growing, and you want to slap them with some sort of a chemotherapy. And the way chemotherapy works is that it kills fast-dividing cells. Now, a lot of cancer treatment, or when cancer treatment was initially invented, was very non-specific, meaning it was just hitting fast-dividing cells. And now, where we are able to send little hoovers on Mars, the medical field has advanced in that way that we are finding more molecular changes, and it's a very interesting and fast-moving field. Having said so, oncofertility is a very, very important aspect of cancer treatment. And my role will sort of be to go a little bit over the epidemiology, the different aspects of oncofertility, not only shining a light on an oncologist, but sort of outlining what a team of cancer expert really entails. Then sort of outline a little bit what the current guidelines are, then treatment and concerns. And I will sort of quote literature and not personal opinion, and then sort of outline a little bit the status quo, and then look a little bit at future aspects. Having said so, I initially thought I would be able to give a little PowerPoint presentation, so I will have to cheat a little bit by looking at my little cheat sheet. Having said so, I included like very nice pictures from a trip to the Redwoods, where I sort of had made some pictures of the nice path we walked through the Redwoods, but I'm happy sort of to forward that to you, and then whoever would like to have their hand out is able to grab that. So from an epidemiologic standpoint, is when you describe infertility or oncofertility issues, is you usually literature defers sort of to patients underneath the age of 45. Having said so, some people might be offended. Same sort of when you look in the geriatrics world, when you say, well, someone who is old is 65 plus. Having said so, that is sort of where I base my numbers. So 10% of all cancer patients in the US, which is approximately 140,000 patients a year, are under the age of 45. And when you sort of look at ballpark numbers in literature, is 40 to 80% of females face the risk of infertility as a result of their treatment or cancer. In males, it's a little bit less, 30 to 75%. And I had some nice pie charts actually from the SEER database that outlines the cancer distribution. Now, in younger patients, usually what you will see is a high frequency of lymphomas, of course the urogenital organs, thyroid cancer as well in females, and then for sure CNS disease as well, which has different implication because that can have some effect on hormonal regulations of endocrine organs and have effect on oncofertility as well. And I sort of had some pie charts on what it looks like in males and females. For sure, in females, it's a little bit more as well thyroid disease, which has different treatment algorithm. And then for sure, there is a rise in melanoma as well, skin cancers, for which we have different treatments these days as well. Now, there are different aspects of oncofertility. So besides having an oncologic surgeon who should and is aware of that his surgical procedures might have some implication on fertility, there is often a radiation oncologist who is aware of the fields of radiation and sort of how, even if a reproductive organ is not in the field, how to sort of preserve that organ from radiation fallout, so to speak. Then we have the chemotherapy as such, which is sort of my role to look at. Then we though have as well psychosexual impact factors. For instance, at university we had a young individual who had a cancer of the vulva and had basically her whole vulva removed, and for sure this is something traumatic. And then socioeconomic impacts. For sure, maybe losing the job or not having the financial resources or going through all your financial resources. Now, for sure, practice has changed over the last decades. There used to be, whenever there is cancer, surgery used to be very aggressive, but we have learned over the years that we can be less radical and more conservative in surgical approaches, and that radiation fields don't have to be very broad but can be very confined, and that we should use organ shielding as well. Then we have advanced diagnostic workup techniques. One of them, for instance, is a PET scan, where you have disease lighting up, and I see I have to accelerate here a little bit, and molecular workup, which shows us how aggressive do we have to be. And then we have literature that supports sort of the cumulative experience of chemotherapy agents. Now, the role of an oncologist is really to be part of a team, since cancer care is really teamwork. It's very complex and it's multidisciplinary. And that is very, very important. Although, for sure, an oncologist sometimes really works as a navigator for the cancer patients. Now, infertility can arise as a consequence of treatment of oncologic conditions. And the oncologist must be aware of situations where treatment will affect fertility. And, for sure we should consider short and long-term side effects of treatment. Long-term effects, for instance, I saw an individual last week who had cervical cancer, had radiation to the cervix, and had significant dryness of the vagina, which sort of impairs sex and then conceiving. And for sure it's important to consider psychosocial distress and there should be an early referral for counseling. And for sure, the oncologist should think about referring patients to a reproductive specialist. Now, chemotherapy effects on fertility do depend on dosing, on the drug, on the age, on male versus female, physiology, and then which approach you really use, whether you use a radical versus an adjuvant approach. And what I mean with that, that's sort of, a little bit terminology from England. Radical meaning, let's say, someone has a very severe leukemia where you eradicate basically all the bone marrow cells. Now, current practices are such that for sure we have to be aware and knowing which agents are cell cycle non-specific. These tend to have a greater effect on oncofertility and seem to do more harm. Or cell cycle specific, something like methotrexate, which are less gonotoxic. And for sure we know that combination treatments are more toxic than single agents. Now, there are very good resources out on the web. One of the resources is from Fertile Hope, and where there's an outline on which agents have a higher risk, lower risk, intermediate risk, and then it outlines you a little bit the costs as well. Now, the current guidelines, I'm on the verge of almost finishing, is that for sure all oncologic societies, whether it's in Europe, the US, or Asia, recommend that all oncologists refer patients for counseling regarding oncofertility options. And there is sort of this nice workflow sheet which was published in the JCO, which is the Journal of Clinical Oncology, where it outlines that once a patient hits your door with a diagnosis of cancer, that for sure that should be discussed. If the patient is interested, he should be referred, and all of this in a timely manner. Now, having said so, there are a few practical concerns, a few sort of literature and ethical concerns, which I want to outline, which is sort of all grabbed from literature, and that's not personal opinion. Okay, so concerns in literature are, from a practical standpoint, is there enough time available to address fertility-related issues? Meaning, is someone with acute leukemia even able to address these issues, or has treatment to be started right away? Then, do fertility options decrease the chance of successful cancer treatment? Very important point. Then there is some concern in literature, is there the possibility of reintroduction of cancer after transplantation of cryopreserved tissue? And a lack of clinical trials and data where infertility inducing risk of certain forms of cancer and treatments are unknown. Now, other concerns in literature is that there are some individuals who outline, and there was just sort of a nice review in JCO that we are really using resources towards something reactive versus then being proactive. And what they mean with that is, why don't we rather use the resources to pour into cancer prevention than sort of acting on someone who has already developed cancer and allocate the resource in a different way. Then there are individuals who say there is a lack of long-term health outcomes research. Then there are concerns about the welfare of the offsprings of parents who have a shortened life expectancy, and then limited resources where some individuals argue that there's an argument that adding insurance coverage for oncofertility, and I'm quoting here, but not expanding health coverage for those without health insurance coverage, reinforces socioeconomic inequality. Now, there is some literature as well on concerns of healthcare disparities. And there is literature that shows as oncologists, were less likely to discuss oncofertility with African American females, regardless of income, and that they were more likely to discuss socioeconomic or oncofertility with socioeconomic equal individuals. Now, what is the status quo? And I'm almost finished. Now, shockingly, although in 2006 already the American Society of Clinical Oncology published the guidelines that oncofertility should be addressed. There was a survey at the big major US cancer centers, the NCI-sponsored cancer centers, and they sort of found that most of them had no formal procedure to address fertility preservation. And there seems to be, or literature indicates that routinely oncofertility information and referrals are not offered. And there was some literature as well that showed that a significant amount of vaginal and cervical cancer survivors reported that their physician never asked them about sexual effects of cancer treatment. Now, I think for future purposes, what is important is that for sure one thing we have to do, especially in Louisiana, is to improve the education on oncofertility. Now, having said so, a lot of the education in the US of physician is based on inner city hospitals, where a lot of times the resources of patients you see are very limited and disease is often very advanced. So my assumption might be maybe the physicians aren't rightfully trained because they might not see these patients, just putting that out there. Although literature surely says you should do so. Then there is this whole new array of targeted agents where we don't even know what sort of effects those have on onco or on the reproductive organs. For sure, we have to improve data collection and clinical trials and assess long-term outcomes of the offspring. And I know I terribly went over my time, and I totally apologize, but I thought these were all important things to bring up.
Fantastic.
So I'm sorry.
No, that's okay. That just means Dr. Broussard only gets 1 minute.
That's okay. I can do a minute. Thank you for allowing me to speak tonight. I'm actually a pediatric oncologist, so my scope of work is a little different than Dr. Reski's. We actually have the privilege of seeing patients from the ages of 0 up until 22 at Children's, but really most pediatric oncologists, our clinical trials go up until about the age of 30. So the ages of patients that we see are varied, and so obviously the topics of infertility and fertility are very different for a parent who has a 2-year-old with cancer versus a parent who has a 20-year-old with cancer, and covering the scope of that is quite vast. So I'm just going to do a little bit of epidemiology, not very much, and just kind of go through what we go through in a day. So by the year 2015, 1 in every 200 young adults, which is between the ages of 15 and 39, will be a survivor of childhood cancer. It's a lot of people out there that are survivors of cancer, which is good news for us. It really means that the cure rates for pediatric cancers are in the high 80s to 90s, close to 90% for many of our cancers. For pediatric cancers, the most common things that we see are leukemias, brain tumors, lymphomas, solid tumors such as bone tumors or soft tissue cancers. And like I said, for the majority of our cancers, the cure rate is really around 80%. We know that the large majority of our cancer survivors do very well in their lives, but even those that don't, even those that function very well, they have needs for surveillance that really exceeds past their time from seeing a pediatric oncologist. And the things that we do surveillance for are what we consider late effects. So what is a late effect? A late effect, the definition is, it's a health condition that persists or develops 5 or more years from cancer diagnosis. And things are things that are commonly reported by cancer survivors. Late effects are those things that can impact almost any aspect of health, and it can include life-threatening to life-altering events. So obviously infertility and fertility issues are some of those events. Late effects contribute to cancer-related morbidity, and they can predispose to early mortality. In childhood cancer, late effects are really a very large spectrum, and they're really related to disease process, surgery, chemotherapy, and radiation. For example, for our leukemia survivors, we know the potential late effects are those such as neurocognitive deficits. They can have processing issues, learning problems. We know if you had received radiation as a leukemia survivor, you're more prone to a secondary cancer. You can have heart problems such as arrhythmias, high cholesterol, increased cavities, increased obesity. It's really a huge gamut. A lot of these problems are not seen for years. So if you are treated as a 3-year-old, some of these problems may not even show up until you're 20, 22 years old. And a lot of times at that point, you're past the scope of seeing a pediatric oncologist, and you have moved away from your pediatric oncologist, or being followed by a generalist or things of that sort. So what does this mean? This means that actually, as an oncology survivor, it is really your job to know what your potential late effects are. And then it is your job also to help educate your potential caregiver, because they may not be aware. Some of the other common tumors that we see are brain tumor survivors, and they have a totally different set of late effects that we worry about. Everything that as simple as a hormone abnormality due to radiation or chemotherapy. They can have endocrine dysfunction. They can have kidney dysfunction, secondary tumors. But a lot of them can also have lots of problems with infertility. For most of our children, the problems with fertility are because of some effect from their therapy, whether it be surgery, radiation to the brain, radiation to the abdomen, or chemotherapy agents. Dr. Reski touched on this. We have a lot of different agents that we know can cause infertility. For example, people who have received alkylating agents, and we know that there are certain limits that will cause infertility. So if you've received an alkylating agent, 7,500 milligrams per meter squared, as a total dose, we know that those people are more prone to infertility problems. But how many survivors actually know how much they've received? That is really the big issue that we deal with. We are, like we said, aware that certain therapies are more likely to cause issues of fertility. But it's a difficult conversation for us to have. The conversation I have with the 2-year-old parents is very different than that I have with the 20-year-old's parents. And I can tell you that when you tell a family that their child has cancer, their number one question we have is, will they survive this? They really aren't thinking 20 years down the road or even 15 years down the road, what is going to happen? I think parents are now becoming more savvy in asking these questions. And unfortunately, we don't have the best tools to arm them with. We do bring up fertility. I know that in all our family conferences, when we first discuss treatment options, we do discuss there is this potential of infertility, but really we don't know. Just because you receive chemotherapy at age 3 and with agents that we know may cause infertility doesn't mean that 20 years later your body may not just react and you may not be able to get pregnant. But it is a conversation that we are starting to have much more often. Currently, our standard of care is for our boys that are pubescent between the ages of really 12 and up. We discuss semen banking really right off the bank, with our very first conversation of diagnosis. I can tell you, the conversation with a 12-year-old is not easy, and most of them have no interest in doing this. The families will persist, but cost can be prohibitive. But really, I think it's just, as a pediatrician, we are not taught to talk about sex very often. It is a very difficult conversation to have with a 12-year-old, and it's an even more difficult conversation to have with a 20-year-old when a lot of them are really close to our own age. We do discuss for infertility issues with female patients as well, but a lot of our cancers are not those type of cancers that treatment can wait. This is one of the things that we do struggle with, that as a pediatric oncologist, a lot of kids come into us very sick. They don't have a month to do Lupron and to get egg harvesting done. There aren't techniques that enable us to do all these things and give them a month's waiting time before they are able to collect their eggs, and that is something we are struggling with. When we know that radiation is going to affect their ovaries, we try to tack them away. We try to preserve these things. But a lot of these things we're not able to do right away. So it is something that we are learning to discuss a little bit more. I think that this forum, Oncofertility and LLS are doing an amazing job of discussing fertility. What I do as a late effects or the director of late effects, my primary goal is to actually arm survivors with knowledge about their treatment. So we have a special clinic dedicated to just pediatric cancer survivors. You have to be off therapy for between 2 to 5 years, and then you come see me in clinic. What I do is I actually go through all your records, and between myself and our nurse coordinator, we get everything kind of situated so you actually have what we consider a passport, which tells you of all the treatment that you actually received, including all the drugs, total cumulative doses, and all the potential late effects you're eligible for. This at least arms the survivor that if they move away or they start seeing an OB, they start seeing a general practitioner, that they have some tool to actually give to other doctors and say, these are things that I potentially am at risk for. How can you help me with this? Because as a 26-year-old, you're probably not going to be seen by a pediatric oncologist, and we may not be the best people for you. But if you have that information, you're armed with that information, hopefully other doctors can help you with that. There are some great resources that we use in order to help figure out what late effects you are at risk for. Survivorshipguidelines.org is a free survivorship resource that is published by our Children's Oncology Group. It is a evidence-based resource that actually helps you figure out what potential late effects you may be at risk for, and that is something that we use pretty readily. So I know the time limit's up, so I'm going to move on.
Thank you. Thank you so much. So I'm going to take about 2 minutes and just summarize what we've heard so far. We heard from Laura, who is a survivor, things that are important, I think, for us as caregivers and physicians. You know, one of the things that benefited her is she had a plan, and that's what we've got to have in place, a plan, so that it's part of the routine, part of care. And I think that's a way that we just don't forget those things. The other thing is she talked about setting appropriate expectations for your patients to make sure that they knew exactly what was going to happen to them to the best of your ability, because their world is already out of control when they get the diagnosis. She talked about trying to hook up your patients with resources, especially when there were some fiscal limitations. And she also talked about the use of online forums, which, at least in my career, even though this is not my area of expertise, sometimes those forums are good and sometimes they're bad. So if you can link patients probably to appropriate forums, I think that would be really helpful. We've heard a little bit about success rates and appropriate counseling and the incorporation of ethics in counseling. We've heard some real numbers that 10% of the cancers in this country occur in patients less than 45 years of age. And so that's a big number of people that we're talking about that this is something that's very important for. Those vary a little bit from adults to children, but lymphomas and leukemias play an enormous role there. And that the care that needs to be provided is a team care. And I think one of the things that we've heard through the extension, through Dr. Prasad, is that it's not only team care, but it is sequential or something that's ongoing, and that's a very important part of this issue. And so you may not always need the same team that you had in the beginning. You may need to have that team change and morph into something else as you go forward. So with that, I'm going to turn the mic over to Dr. Sartor, who's going to talk about some of her experiences with the exact techniques and what's really available. I mean, it's pretty amazing what can be done right now, and how complex that conversation may be that she has to have with patients.
10 minutes? Is that all I get?
Well, you actually only get 6, but that's okay.
Is this working? No. Working now? Okay. So I was, I guess, given the task by the organizers to review what's available as far as fertility preservation, in both for females and males. And since I am a predominantly female doctor who takes care of women with fertility issues, I will be very brief related to the what's available for both boys and men. And I think it's really been covered pretty quick. Already mentioned But when men are diagnosed with diagnoses that will compromise their gonads and therefore compromise sperm function and therefore future fertility, the standard of care is to freeze sperm. And I know there have been a number of things that have, a number of remarks about cost. And actually, the cost is really not prohibitive. It'll vary from program to program, but you're looking at about $150 to $175 for a freeze. And then, again, depending on the program, the storage fees per year are going to be not too much, probably around that figure as well. So it is something that can be done. There are programs in every city. There's one here that we refer patients to called Reproductive Resources. As far as boys are concerned, really it depends on whether or not they are making sperm and whether or not the sperm can be reached either through masturbation or actually stimulating the pediatric patient under anesthesia to ejaculate. The point between when a boy is not making sperm and producing sperm, there are no easy landmarks for that. So some 12, even some 11-year-olds, if we biopsy the testes, you can find active sperm in there, sperm that can actually fertilize. But because there is no landmark, external landmark to tell us that that's happening, then the best approach with prepubertal and peripubertal boys is to take testicular samples, to do testicle biopsies of the testes and then freeze these. The freezing techniques will vary according to whether or not you think you do have mature sperm in there or you don't, or you have very immature or what are called spermatogonia, which are the sperm that haven't differentiated yet and cannot fertilize, have not achieved the haploid status. All of these freezing techniques are in active investigation right now. And what is happening throughout the world is these young boys are having their testicular tissue retrieved and frozen. But if there are not any mature sperm cells in there, the actual ability to then take that tissue down the road and mature the sperm and either get the stem cells out of there and mature them to mature sperm, or take the tissue and inject it into the testes that still remains after treatment to see if you can get the stem cells to start producing active sperm. None of that has really happened. And so the thing about these technologies is sometimes you have to go on a wing and a prayer. You have to assume that the technology is going to progress to a point where we will know how to proceed and we will know how to get to that sperm that can actually fertilize an egg. As far as women are concerned, girls and women, but I'll start with women, there are right now 2 procedures which are considered no longer experimental. One is actually freezing of the fertilized eggs, or cryopreservation of embryos. The first cryopreservation was done in 1984, and since then we've had hundreds of thousands of babies born from that type of technology. In the year 2010, there were 50,000 babies born from thawed embryos that resulted from that technology. It is felt to be safe for the most part, and when I say safe, I'm referring to the offspring and whether or not they are born with increased abnormalities, whether or not there are issues down the road, late issues down the road. And you'd think that, well, at this point in time, 1984, first frozen embryo successfully born, we should know whether or not it's entirely safe. But there are still ongoing long-term studies looking at this. And when a new technology is developed, I think the first question is it really going to work? Is it going to get us to the goal that we want? The second question is it safe? Is it safe for the person, and is it safe for the offspring? So embryo freezing requires, as Laura very nicely described, does require a process in which you have to take fertility drugs to mature multiple eggs, have those eggs retrieved, have them fertilized with the sperm, and then the resulting embryos are frozen. That process takes around 3 to 4 weeks, and therefore it can delay therapy. So whether or not it's something that really is available is going to depend on the health of the patient when the cancer is diagnosed, and whether or not the delay is going to compromise her long-term survival. This is not, as far as breast cancer is concerned, there is an opportunity between diagnosis and surgery, and an opportunity between surgery and chemotherapy in which we can undertake this and give the drugs and retrieve the eggs and do the freezing. And there have been several studies to show that it does not prolong the time from initial diagnosis to when chemotherapy is begun. And there also have been studies with, and I know this is not this is the Lymphoma Society, but there have been studies done with the breast cancer patients who've received treatment, and it does appear that their long-term prognosis is not only compromised by doing the fertility treatment, but in fact those women that end up conceiving seem to have a better prognosis, and those are studies referring specifically to breast cancer. So the problem, of course, with freezing of embryos is that you have to be in a relationship with someone that you expect to parent and spend hopefully the rest of your life together with. Or you have to be accepting of using a donor sperm to do that. So the other option, which has recently been removed from being considered experimental to now something that can be provided nationwide and in hopefully all IVF clinics, is that of egg freezing. And obviously the advantage is you don't need sperm to do that. So if you are a young post-pubescent female, or you're a female in her 20s and 30s that hasn't married or found the young man that you wish to reproduce with, this now gives you that option to preserve eggs. The eggs are funny things. They're not that easy to freeze. They have a high water content. And at the time that eggs are retrieved, at the time that they come out and are mature, the chromosomes inside the egg are lined up in a certain way that when you try to freeze them, you can end up with a lot of damage of those chromosomes and the mitotic plate. And that's one of the things that's made it difficult for many years. So the first IVF, the first frozen embryo was accomplished in 1984. The first frozen egg that ended up with a pregnancy was accomplished in 1986. So it was only 2 years later, but then everything stopped for about 10 years because the results were just dismal. And what has happened in the last few years is a new freezing technique that helps us do this so that eggs will survive the thaw and that eggs will be able to be fertilized. So there has been that recent technological advantage. The particular technique is called vitrification, and it's a very fast freeze technique And it's also a technique that we have now converted to using with the embryos. And we're seeing much, much better survival, both with embryos and now with the eggs. So that has allowed us to be able to offer this to patients. But I have to tell you that, so in 2010, there were 50,000 embryos that ended up as live-born babies. As of today, in the whole world, there are about 2,000 babies that have resulted from frozen eggs that were thawed and then fertilized. So the amount of experience is still relatively small, and most of those are not from eggs that were frozen for cancer concerns or medical reasons. Most of those are from young women, and they're being used for women who need egg donation. So it's the data it gives us a lot of hope to be able to see that this is an option, but you do have to realize that all the great success rates that you're seeing related to frozen thawed eggs is not necessarily the same population that we're trying to help, and that is patients who are going to lose function of their ovaries because of some sort of medical treatment or radiation treatment. So the other question is it safe? Does it work? It appears to work on certain populations. Number two, is it safe? And we think so. There in 2009 was a paper that was published looking at over 900 babies that had been born from being frozen eggs and then thawed and fertilized. And there did not appear to be any increased incidence of fetal abnormalities or chromosomal abnormalities. But 900 is a small number when you look at the fact that we have hundreds of thousands of babies that have been born from frozen embryos, and it's still not entirely clear that it's a completely safe process. But of course, when you're looking at whether or not something should be done, you're always weighing risk and benefit. And the benefit of being able to be fertile and have a child probably far outweighs the risk that perhaps there may be some issues, perhaps small, over the long term with these children that are born. So those are what's available now, and about 50% of fertility centers, IVF programs in the country now offer egg freezing. The third option is experimental, and it still has a lot to be, there still is a lot that has to be worked out, just like with freezing of testicular tissue, and that is freezing of ovarian tissue. And that is an option that is really the only option for girls that are prepubescent, so girls that have not started ovulating, and that requires, of course, the ability to harvest those the ovaries, and that requires surgery. And when it is done, either pieces of the ovary, like the outer cortex, the outer covering of the ovary, is removed, and then it's cut into small pieces, and then those are frozen. When they are transplanted back, they can go back into the pelvis near where the ovaries normally should go, either in the side wall, or what is being done now is the ovaries that are, the pieces of ovaries that remain after therapy are being, that area, that outside, the outer cortex that was removed and has subsequently healed up is being stripped off again, and an area made ready for those pieces to be placed back on. So they're taking the ovary that already has a blood supply and putting and sewing those little strips together and then attaching them back on the ovary where they came from. And that has looked, the success with that has looked quite promising, but It usually takes anywhere from 2 to 3 months to start seeing function where estrogen is being released by those areas now. And there have been, at this point in time, 29 births that have resulted from ovarian tissue transplantation. So again, that's not a large number, and there are a lot of issues that need to be worked out. For example, when you look at these graphs, they appear to have a shortened lifespan. So about 20% of those grafts are dead within 6 months. So again, looks hopeful, but we're not there as far as saying this really works. And hopefully that will be coming as groups work on it. In the world, there are, in Belgium, there's a group that's done a lot of work with ovarian tissue transplantation. And in the U.S., there's a practice up in St. Louis who has also been working with that and publishing on it, but still relatively small amount of success worldwide. Other opportunities for fertility cryopreservation are what about, are there any drugs that we can give patients before they undergo the chemotherapy? And Laura had mentioned Lupron, which is a GnRH agonist. And the concept behind the use of it is, as she had said, that it puts the ovary in a prepubescent quiescent state, which would hopefully not make it as vulnerable to the effects of the chemotherapy. It's not entirely clear that it works. Some studies are affirmative, and some are not affirmative. And the problem with these studies is that what they're using to define ovarian failure. Unfortunately, the way these studies have been designed is that they have defined ovarian failure and menopause as having no menses. But there are women who don't have periods who are not in ovarian failure. And there are women who have periods who actually have very, very poor ovarian reserve and really are not fertile. So what some of the problems with these studies has been the endpoints that they've used to study, as well as the time that they've followed these patients after they've taken the Lupron during their chemotherapy. You really have to follow these patients out longer than 6 months and longer than a year, and the majority of the studies have only done that. So there are some studies moving forward looking at that, but we really don't know the answer. If your patient cannot access embryo freezing or egg freezing, then it probably is a good idea to recommend that they do take that medication. And it's relatively inexpensive when you compare it to egg freezing and embryo tissue freezing. Let's see, I think I've pretty much covered the options. It's very exciting. There's a lot of hope right now revolving around our ability to help patients. I think from my point of view, what's most important is the oncologist needs to be the conductor of all of this, and needs to be able to pick up the phone and call the fertility specialist and get that patient to the doctor right away. And it needs to be a team process, I think, as both of you have alluded to multiple times. So anyway, I think I don't have much else to say. Like Dr. Reski, I'm used to PowerPoint presentations, and I think I've pretty much covered it. The one point I want to finish with, and again, that's sort of underlying what's already been said, is that when you look at patients who are under 40 that have been diagnosed and treated for cancers, less than 10% of them end up having children. And that is really not, that's really a distressing number to me. Why does it happen? It happens in part because they don't get adequate information. They're not getting adequate counseling, not getting adequate referrals to the people that can help them. There's also a lot of fear. Is this going to hurt my offspring? The studies are very reassuring that the chemotherapies does not leave lasting effect on those gonads. On the eggs and the sperm. As far as the offspring having an increased incidence of defects. And I think that at the time of the diagnosis, it is, particularly for pediatric patients, it is a very uncomfortable conversation to have, both with the children and the parents. And it's just a hard time. But I think we all have to double up our efforts at trying to get that information and helping them navigate through the right channels to get to the right treatment.
Thank you, Sissy.